Hello, folks. Hello, everybody. I'm Dr. Elizabeth Leroux. I'm a neurologist. I'm a headache specialist, and I'm the chair of Migraine Canada. So our association and our team is very, very happy to welcome you tonight during June, which is Migraine Awareness Month, to this event where we're going to talk about migraine prevention. But before we dive into it and we spill the beans about migraine prevention, we are going to just say, I'm going to introduce ourselves. So who we are a national association supporting all Canadians living with migraine and also other headache disorders. So intracranial hypotension, cluster headache, post-traumatic headache. We want to be active for everybody. We are a not-for-profit. We are not charitable yet, so hold your donations, but very soon. Our board is a multi-skilled, multi-provincial, diverse board, all volunteer. And we are glad to have Wendy Gerhardt, our wonderful executive director, and Renda Basil, our fantastic social media coordinator, and a lot of people who work with us as volunteers. So we are a young association, and we really want to help people with headaches and migraine. We are supported by the pharmaceutical industry, and we have numerous partners, which names are listed here in alphabetical order, and we thank them for their generous support. So one little thing before we get started, I am a neurologist and I'm a doctor, but what I'm going to say tonight should not replace medical advice from your treating physician. So we provide information, facts, science, but we cannot advise you on your particular story and your own medical condition. So whatever you make for medical decision, please discuss with your personal treating healthcare provider, because your story is your own. And there are things I might say tonight that might not apply to you. So tonight we talk about migraine prevention, the path to relief. And we know this path can be long and arduous, and sometimes it can be a struggle to find a good balance in your life and have less migraines. So the thing is, if it's any comfort, and I always start with this because a lot of my patients tell me they feel very isolated, which is strange because migraine is actually one of the most common diseases of all diseases. And this is not only in rich countries, sometimes we have this kind of bias. It is for the whole planet lives with migraine. There might be a bit less in Africa, but otherwise we think that 11% of the world's population lives with migraine, and 1 to 2% lives with chronic migraine, which is roughly having a headache or migraine more than 15 days per month. So you're definitely not alone. And if you live with this, I just put a few sentences I'm sure you've heard before. And with different, if you live with migraine, you'll meet a lot of good-willing individuals. They might be your family, your networks, your coworkers. They might be someone you're just meeting, telling you a bunch of things. And sometimes it's a bit difficult to tear, what makes sense to what doesn't, or if you're told that maybe salt and water will help you and you've been struggling with migraine for years, sometimes it becomes annoying. So there's a lot about migraine because it is so common and it is part of our society. So no wonder there's a lot of popular knowledge or myths about migraine, and things that may be true and things that may be not true or partially true, as we know happens in science. But if you're here tonight and if you are logged in, it's because you want to do something. You want to get better, or maybe you know someone that you want to help, and you want to improve your quality of life. And this is what we're going to talk about tonight. So here's an overview of what we'll talk about. When to use prevention, right? What is prevention and when to use it? What if you would prefer to avoid taking medications and you're interested in different lifestyle interventions? And then we'll talk about medications, and roughly they go in steps. First, the pills, and then we have Botox and CGRP antibodies. And then there are what we call third line therapies that are usually also pills. We are an association, so we advocate for access to care. And that means we have to talk a little bit about money, cost, insurance companies, patient support programs, and so on. We'll also say a few words about the neuromodulation devices that can be helpful for migraine prevention, and something you may have heard about, the GPANs, a new class for migraine treatment that is probably going to come to Canada next year. And end on a bit of advocacy, a to-do list for you. I know you have tons of to-do lists, but this one should be a good one. And of course, hope that there is something out there for you. So our motto as Migraine Canada is no one size fits all. This is very important because whatever we discuss, it might be very good for someone. It might be absolutely of no use for other people. And it might even actually cause side effects or difficulty. There's no unique cause for migraine. There's no 100% cure for migraine. If anybody is telling you that something cures migraine in everybody, it is not true. Maybe someday, but not today, not in 2021. So migraine is a brain disease. Okay, it's a brain disorder, and it's actually something that is along a continuum. So some people have what we call low frequency. They have a few headache days, a few migraine attacks per month, or even sometimes a few per year. Lucky people. I mean, that's less than other people have sometimes, but still attacks can be disabling. Some people will have high frequency. So that roughly we define this at 8 to 14 days of migraine per month. And then some people have what we call chronic migraine, that's 15 days and more. All those limits are arbitrary because most people actually fluctuate along the spectrum. But some people remain at the same frequency for years and years, and other transition to chronic, other revert, and they go back to episodic. So wherever you are on the spectrum, migraine prevention could be interesting for you. And tonight, I'm sure we have people who have tried a lot of things already. And I'm sure we have some people who have not yet started their path and they're wondering what's out there on the menu. So we'll say a few words for everybody and hope we can help. Let's recall also that, why are we treating migraine with prevention? So prevention, when we talk about stroke, is we don't want the stroke to happen. In migraine, it's different. It's like asthma, it's like attacks are happening. You live with it already, but we want them to be less frequent and less severe. So the migraine brain is different. I mean by that, migraine is not imaginary. There's something in the brain, and it's something about electricity and chemistry that leads your brain to be hypersensitive to certain triggers. You know about triggers, and those triggers build up and then trigger the famous migraine attack. And so all of this is addressed in another webinar that is on our YouTube channel, which is the Science of Migraine. If you want to hear more about that, I definitely encourage you to look at it. But just to remind that when we try to prevent a disease, we have to have a bit of an idea what this disease is. And so the migrainous brain interacts with the environment. And when I say the environment, it's our body environment, and it is the environment around, right? The lights, the sounds, the smells, the weather, and then the food, our emotions, our hormones, our pains in the neck and in the sinuses. So when we want to improve the migraine situation, there's two things we can do. We can raise the tolerance of the brain to triggers, and we can decrease the load on the brain or the triggers. Stabilizing lifestyle, which we'll talk about, is good for both aspects, right? It makes the brain more resistant, and it can also decrease the triggers. And migraine preventives usually will act on the brain chemistry to make it less prone to attacks, more resistant. That's what they do, all of them, one way or another. So when we talk about treating migraine, it can be a mix of different things. So it's always three parts, and that's another thing that you might be familiar with. But when we talk about migraine treatments, there's always a behavioral part. Behavioral part means what you do in your life, right? So lifestyle and putting your brain in a good place, in a stable place. Acute therapy, we don't talk about it. I just released podcasts about this, and we can definitely do webinars about this. So that's treating the attack as needed. Prevention is lowering attack frequency and severity. So if most of the patients I meet and who are starting their journey, they say, well, what can I do if maybe I'd like to either avoid taking medications, or, I'm taking medications, but I like to optimize my situation. What can I do? There are two ways to look at this. One way is to avoid triggers, which can make a lot of sense, especially if the triggers are clear. But sometimes when the migraines are so frequent and you have them 20 days per month, well, a lot can happen on 20 days, right? The weather can change, you can eat a lot of things, a lot of emotions, a lot of things, and it can become a bit stressful to watch for the triggers all the time. So one revert way to look at this is to optimize protective behaviors. So things you do that protect your brain. And the list, it's exercise, healthy eating, hydration, pacing your energy, protecting your sleep. All of this can be difficult or complicated, especially if you have a lot of migraine. But it's just a bit of an interesting way of, looking triggers versus protective behaviors that are more empowering than sometimes getting afraid of having triggers. But of course, if you have triggers, it's good to be aware of them. So when we talk about lifestyle and about non-drug approaches, and I'm not going to talk tonight about all the other non-drug approaches, but they are important: massage therapy, osteopathy, chiropractic medicine, acupuncture. All of these can be part of your menu to help with migraine. But those are the C's. So sleep, exercise, eat and drink, diary, and stress. All of this you can manage. In stress, let's just say that stress is not always being anxious about what can happen. It can mean a lot of things. So in this part, usually we include dealing with emotions, dealing with energy drains, pacing your schedule, planning for buffer time, and all the relaxation world: breathing, cardiac coherence, mindfulness. There's lots that can be done there that can be extremely effective with persistence. Here's a slide that comes from a deck that we are soon going to give to doctors, right? So we want to tell doctors how to assist you guys in putting these habits and these lifestyle things in your life. So let's look at them just for fun. So we want the doctors to validate that migraine is a neurological disease and can be very disabling, very important. We want them to help you setting realistic expectations, and we'll talk a bit more about that. We want them to understand, and also you as a person, as a patient living with migraine, that this is a long journey. Some of you might say, hey, I know that, baby, I've been there for 25 years. But it's important for those who are starting that this can take a while and multiple trials before finding the right mix. Lifestyle changes take time, patience, and persistence, and it can be really sometimes challenging, but with persistence, it can really be helpful. And even if you do all of it and you are a yogi master, you meditate, you train, you hydrate, you've done it all, or you're just too sick that you cannot do these things, migraine can be disabling and can require medications. Okay, so even with the best lifestyle, sometimes, just like asthma, just like diabetes, just like any other chronic disorder, medications are needed. Okay, so let's say you say, okay, I've done my lifestyle thing and I looked at what I could do. I would like to try medications. So what are the goals of preventive therapy? Obviously, getting better. You want to have less migraines. You want to be, to have less severe attacks, ideally none maybe. But usually we consider success as a 50% reduction in frequency. If you live with chronic migraine, a 30% reduction is actually significant, because that can be going from 20 days per month to 14 days per month. That's a full week gain. So that can make a lot of difference for you. We want the attacks to be easier to treat, to be less intense. We want less symptoms that are nausea, vomiting. Ideally, you don't have to go to the emergency department. We want less disability, higher tolerance to triggers. So maybe you can exercise, or maybe you can have a little glass of wine, or go to a restaurant or go out. And we want less anxiety, depression, and irritability, because when you live with a lot of migraine, that can happen. Okay, so before people go to drugs, sometimes they will say, I'd love to try supplements. There are 4 official kind of supplements that are studied for migraine: magnesium, vitamin B2, coenzyme Q10, and butterbur or Pittacidus hybridus, which is a kind of a root. This one is a bit less recommended now because there are concerns about liver toxicity, but there are also safe ways to get that. So let's say that you have to discuss this with your healthcare provider, but the others can all be taken all by themselves or in supplement pills that combine them all. And if you want to go that route, you can. My comment about supplements is that treat them as drugs, really, because I've seen patients, they take vitamin B2 and magnesium for like 10 years every day, and they're not sure if it did anything. So if you do a trial, do it and see if it helps. And if it doesn't, stop it, right? There's no point paying and taking more pills if they're not helpful. So when we start medications for migraine prevention, there are a few things that sometimes your doctors will, they will make a few mistakes. So sometimes they underestimate the real state of things, because people with migraine tend to just look at the worst attacks. So sometimes some of them will say, I have 8 migraines per month, but they have 8 migraines, but then they have 10 other little normal headaches, which does 18. So underestimating the baseline is something that doctors do very frequently. And even my patients, when I ask them to do a diary, they realize that the situation is a bit different than what they thought. So it's nice to have a good baseline. Another problem with drugs is I hear my patients all the time say this. It's like, my doctor just gives me drugs, and they are not even drugs for migraine. This is true, and we'll present the drugs. They are for other conditions. But in the end, all of these drugs have a way to act on migraine. And I think it's very important that people understand that. So your doctor, ideally in a world with plenty of time, would explain to you why those drugs are prescribed for migraine. So I think this is something that is lacking in our system, where time is very short, and often doctors will say, take this, take that, do this, do that. And there's not really a conversation about it. If something doesn't work, why keep it, right? And that's true for anything, supplements, drugs, or behavioral practices. And the other thing is that I hear a lot from my patients when they make it to me or another headache specialist. They've been told sometimes by their GP or even a neurologist, there's nothing else I can do. Don't accept that. I mean, yes, there are people who have really tried the whole thing, and then we have to find ways to help. But often people are told there's nothing else. But as you will see in 2 minutes, there's a lot that can be done. So don't lose hope and ask to be referred to a specialist. When you start a drug, another mistake that often happens is that the trial is not long enough and the dose is not high enough. So I've seen quite a few patients who tell me, oh, I've tried this drug at this dose for like 2 weeks, it didn't do anything, or a month, it didn't do anything, or, I had the side effects for 2 days and I stopped it. So the side effects come first, and then comes the benefit. So try to bear through some side effects if you can. And then if once you're past that time, because usually, not all the time, sometimes side effects will get better, and then the brain chemistry adapts, and then the migraines get better. So persistence is important. Then patients often want to know, if I take a drug, am I going to have to take it for all my life, right? Of course not, right? So the idea is, if you take something, well, the idea is to say, okay, every year or every 2 years, depending on your story, reassess. How are you doing? Are you better? And if you are so much better, then maybe you can withdraw the drug progressively. That can be done. Can be done for anything: antibodies, drugs, supplements, Botox, anything can be withdrawn after a while. But if you're starting a drug, it's because you want to get better. And if you do get better, well, sometimes it's nice to stay that way for a little while. All right, so pills. So pills for migraine. There are roughly, I'm not going to go into deep detail because I want to give an overview tonight, but there are roughly three main categories of pills for migraine prevention. All of these categories are drugs that were designed or prescribed for other conditions. So there's the antidepressants that are treating the mood or anxiety, anti-epileptics for epilepsy or seizures, and anti-hypertensive or hypertension drugs. And I've put here the brand names and the generic names because just to make our lives easier, there are different names for all these things. So, for example, Elavil is the brand name for amitriptyline, and Topamax is the brand name for the pyramid. All right, so if we look at all of these, there are more, right? I didn't put the whole thing. If you want to see the whole thing, go on our website. There are lists and tables with everything in there. But those are the key ones that are used. So all of these have roughly ballpark estimate 40 to 50% of chance that you will improve by 50%, right? So that means that it's flipping a coin. If you try one of these drugs, it's kind of it's a hurdle race. So you try one and there's no way at this point to know if it's going to help or if you're going to have side effects. So pills are none of these pills are the best or favorite. Some have different side effects. Some lead to weight gain or drowsiness. Others might lead to brain fog or memory issues, and others might lead to low blood pressure. So when you decide for a drug, be aware that it's a trial. You try it, you increase the dose, you can speak with the pharmacist. Hopefully you don't have side effects. If you have side effects, you stop it, and then maybe you try something else. So that's approximately how it works when you want to try drugs for migraine. That slide is a bit too busy, but it's because it comes once again from a medical deck. But it's just to summarize the current state of things, right? Those are not official guidelines. This is just how things are working in doctors' offices across country for migraine prevention in 2021. So first line in purple is what we just discussed, evaluate if you want to start a preventive approach, establish your baseline, start a diary, discuss options, and then get started. Then the first lines are usually oral meds, so pills that we just presented, and ideally meds that have good evidence for effectiveness and a low or relatively low side effect risk. It doesn't mean they have no side effects, but they have probably less side effects than other drugs. And then once you've done that, you will access what we call the second line. So the second line are drugs like Botox and CGRP antibody, which we'll talk in a minute. And then if those don't work, then you can try what we call third line options, drugs that are effective, but usually not that well tolerated. Roughly put, it looks like this. A little note, Botox is indicated in Canada and across the world only for chronic migraine. So people who have 15 days per month plus. Okay, so let's say you've tried oral pills and you've tried, let's say 2 or 3 of them. Well, and you're still struggling with disabling migraine. So CGRP antibodies, they are a revolution in migraine world. This is 30 years of research, and tonight is not the night to talk only about CGRP antibodies. If you'd like to know about them, please watch our webinar. It's on the YouTube channel. And I gave a 2-part webinar only on CGRP antibodies, how they work, their side effects, their effectiveness. So here they are just depicted, so you know what they are called: Aimovig, Ajovy, Emgality, and soon to arrive in Canada, Vyepti, which is an IV infusion. It's a perfusion intravenous. So CGRP antibodies are all injectables. That's because you cannot digest antibodies. They're not going to work. And if you want to learn more about them, look at our webinar. This being said, I will just give you the ballpark for response. So I told you for pills, it was flipping a coin, 40, 50% chance. For CGRP antibodies, well, we look at episodic migraine and chronic. So for episodic, the ballpark is 50 to 60% response. And for chronic, it's 40%. So 4 people on 10 will have a 50% response. And then there are what we call super responders. So people who improve 75%. So that's, means going from 21 to maybe 4 or 5, massive difference. So those people, maybe 1 in 5 for chronic migraine will have this, and 1 in 3 for episodic migraine. So just to give you an idea, not everybody respond, but people can respond partially or very well. And I'm not going to talk about side effects and details. Look at the webinar for that. Botox therapy has been approved in Canada for chronic migraine since 2011. Guys, if you'd like a webinar on Botox, I'm very happy to do one. I've been injecting it for 10 years. And in summary, everybody asks me, where did they put the Botox? This is where that's where there are sensory nerves, the forehead, the temples, the back, the shoulders, where the pain is. And Botox acts mostly on sensory nerves to kind of quiet down the hypersensitive pain system of chronic migraine. It's a fascinating toxin, really. And the success rate, 50%. There's no 100% in migraine world. Quite well tolerated. And like I said, if you'd like to have a webinar on Botox therapy, I'm happy to do one. Okay, so those of you who I'm 43, those of you who remember Indiana Jones maybe have seen the third movie, which is in Indiana Jones and the Holy Grail, or is that the name? Yeah. So in this movie, Indiana Jones has to kind of pick the right cup from a bunch of cups, and if not, he's going to die. So with this, I wanted to say that it's a struggle, and I see a lot on social media and patient forums. What is your experience with this? What is your experience with that? What is the best thing? What if I have sinus migraines, weather migraines, menstrual migraines? Can we predict which drug will work for me? We can't. In psychiatry, there are some genetic testing that can be done. Hopefully we'll have that someday in migraine, but so far it's not possible. Sometimes your doctor will choose according to your medical profile. So for example, if you cannot sleep, he will give you a drug that can promote sleep. Or if there's like epilepsy, obviously you're going to have a drug that treats both epilepsy and migraine. But for most of you guys, we just try the best we can, and we try to navigate this without knowing really what will work. So now let's talk a bit about money, right? So, okay, let's say you've walked the path and you've tried different things, and then you make it to Botox or CGRP antibodies. Obviously, these treatments are more costly than the pills. And so the question is, well, what about my insurance company? In Canada, people might have private coverage. That's approximately 60% of Canadians. They might have public coverage, approximately 30%. And there's maybe 10% that who don't have coverage. They have to pay out of pocket. And that's quite a difficult situation. So let's talk about the private insurance first. So the thing about CGRP antibodies and Botox is that the criteria for coverage vary a lot. So some plans might not cover them, and some plans might cover them, but they will ask for, tickets or tokens or things, proofs, criteria. Here is what the criteria are usually. So this is kind of roughly what we see, because I fill these forms every day, every week, many. So usually insurance will ask for this. You have to have 8 days per month of headaches or of migraine per month, at least. You have to have tried and failed or not tolerated 2 or 3 or more sometimes oral preventives, ideally from different families or classes. Your physician will have to fill a form to give this information. And then the patient support program, which is something we see with CGRP antibodies, so programs organized by the pharmaceutical company that sells the product, will support patients to navigate insurance, and answer questions, help you with the injections, and sometimes also provide what we call a copay, which is kind of a financial assistance if you continue the drug and your insurance company pays part of it, the PSP will pay part of it as well. So this is something that might not apply to you, but it does apply to some people with private insurance. If you try one of the CGRP antibodies or Botox, the insurance company will ask for a proof, right? So the proof might be a headache diary, numbers of days, and questionnaires or different scales or that you have to fill. All of this is done with the help of your doctor. What about public drug plans? Okay, so that's something that is quite interesting. We could do a full webinar on this. Let me just walk you through it. So how does it work for a drug to be covered by a public drug plan in Canada? For the record, I'm a doctor, I'm a neurologist, I work in advocacy. I didn't know any of this 4 or 5 years ago. And I doubt that all of my colleagues in neurology know these things, right? This is not something of common knowledge. Okay, so let's say a pharmaceutical company puts product A and says, okay, the Health Canada approves it, it's safe, it's effective. Then they can submit to CADIF. So this is a public agency for drugs, technologies, and health. So CADIF will look at all the results of the research about the drug and say, okay, you know, it looks like it has a value to treat people, and the cost could make it's possible that the cost could be worth it. So that's the first step. When this happens, Migraine Canada gets in, right? And we propose a report. So we act on your behalf and we ask you to participate in surveys, to send CADIF and say, yes, people with migraine need new option because migraine, is disabling. And here is what people with migraine go through. This is our role. This is what we do. And then this is a public thing. The reports are public. You can find all of this on their website. Once CADIF says, yes, yeah, we recommend that this is covered, then it goes confidential. It goes to something called a PCPA, where all the pharmaceutical companies sit and they discuss about what cost would be reasonable to price this drug in Canada, right? And those discussions can take a while and they are confidential. Then they come up with a cost, a reasonable cost for our country. And then all of this goes to the health ministry of your province, right? And at this level, this is the final decision to say, based on what CADIF says, based on the cost that is agreed by PCPA centrally in Canada, are we, Quebec, Ontario, Alberta, cover this drug? And this is where Migraine Canada can also act with advocacy and by actually writing to the health ministers and saying, hey, migraine is common, migraine is disabling, and so on, right? So this may look dry to you, but it is extremely relevant because it is actually how you can access drugs if you are on public coverage. And once this is done, usually the public coverage will work exactly the same way with criteria and forms that doctors will have to fill with your information. Okay. So we covered quite a lot of ground. So we started from, when to start prevention, lifestyle, supplements and pills and Botox and CGRP antibodies. I wanted to just mention and say a few words about neuromodulation devices. That's another webinar we could do if you want one. So these devices are not chemical. They don't enter your body, right? They act through stimulating the nerves to modulate the pain system in your head. And by doing so, they quiet down the migraine activity. So Cephaly has been around for a while. You can buy it easily. You don't need a prescription for it. I think to the last minute I checked, it was 300. I'm sorry, my cat is. It was $350 to buy one of these. and it sends impulses on the forehead, modulating and decreasing migraine frequency. So there's reasonable evidence about cephaly, especially for episodic migraine. Gamma core sapphire is a vagus nerve stimulator. The vagus nerve is a nerve that runs to the neck. It goes to the body, organs. It is a very interesting device. I think we should soon, we'll have a page on it, promise. And so this device has effectiveness also for migraine prevention. The problems with neuromodulation devices, and I'll be very honest, they require you to use them regularly, and that's the way it works. It doesn't take like days or even weeks. It takes multiple weeks of regular use to actually provide the benefit. And the costs can be also prohibitive. So gammaCore will cost, for example, I think it's around $600 per month, and that's not easy for everybody to afford. And coverage is also difficult to negotiate. So I think these options can be very interesting, especially if drugs are not an option, or if someone cannot use medications, or they want to try something different and very well tolerated. But there are pros, but there are cons. So we can talk more about this maybe in a future webinar. GPANs. So if you follow the migraine activity, you might have seen the names Ubrelvy and Nurtec from our neighbors in the US. So GPANs are new drugs. So they are actually pills that block CGRP. So we have antibodies for CGRP, but these are pills that block the CGRP receptors. So Ubrelvy and Nurtec are approved in the US. They are not yet approved in Canada. Atogepant is a preventive drug. And so here you can see the big change. The big change is that these drugs are acute and preventives. Interesting, right? So if you use acute meds for migraine, you probably know that if you use them too often, you fall into the dreaded medication overuse situation where you have more headaches because you're taking too many Tylenols or triptans or opioids or whatever. So this was a dogma, and this is something very difficult to deal with, because the more migraines you get, the more you want to treat, and so on. With GPANs, it might actually reverse. You might say, I use a GPAN for my attack, I block CGRP, and then the more attacks I have, the more GPAN I take, and I'm not going to go into overuse. It may actually protect me against further attacks. This is not proven. This is not yet proven, but we can just deduct that if a GPAN can be used for prevention, it's very unlikely to cause medication overuse headache, right? So this is something very new. This is very interesting, and they are expected in Canada, hopefully in 2022, maybe 2023. We will see. Stay posted. Hey, so all this is very new. This is very new for me, a headache specialist. This is very new for my neurology colleagues. This is extremely new to family practitioners. So the truth is that doctors in general, in this country particularly, don't have a lot of training on headache medicine. So the last 3 years since the arrival of Aimovig in 2018 have been a show of new things, of new science, of new data. So things are evolving quickly. You know, insurance companies, advocacy, policies, and science, of course. So all of this moves so fast that for some doctors, you know, you cannot expect them to be on top of everything, especially family practitioners. So more options also lead to more questions and more complexity for you when you make your decisions. And so you might say, okay, I want to see a headache specialist now. But if you probably know that waiting lists to see headache specialists are very long. One of the reasons for this is because there's not a lot of incentives for young neurologists to become headache specialists in this country. I'm making a political point here, something dear to my heart. I think headache medicine should be taught way more during residency programs in neurology, so your neurologists are better trained, and more neurologists decide to take up headache medicine as a specialty or as a, you know, something that they want to be good at. So that's a problem that we will address hopefully in the future. Okay, so I look at the time. Perfect. So I have a few more minutes and then you can ask questions. you're here because you're interested, because you want to do something, because you want to get better, right? Or maybe help someone you love getting better. So here's a little list of things you might decide to do after this webinar. You might go and explore our information resource. The web is a fantastic tool, but there's a lot out there that might be great. There are very good sources, Migraine World Summit is one, the American Migraine Foundation is one, but Migraine Canada is your Canadian source of migraine information. So the migraine tree is our way of putting this out, right? And to you. So this is a library of 120 pages on different topics. The way it's organized is that if you look at roots of the tree, roots are all about the types of migraine, the types of headache, the interaction between migraine and other health conditions, a hormone issue, children issue. So the roots are really where you start from. Then we go to the trunk. So the trunk or the core is basics. What everybody with migraine should read and should know, right? So this is is to be explored by virtually anybody with migraine. And the branches, as you can see, they're all equal. There's not one bigger, there's not one smaller. They're all equal because if you live with migraine, you will have to look at different options. So all branches are about lifestyle, as we discussed. Social life is to be built up, and we want to have actually your input about this, how to organize your life with your friend, your family, your colleagues. Acute therapy, preventive therapy, devices and neuromodulation, and procedures and injections. So I encourage you to explore this. And for example, if you want to read about prevention, this is the branch of prevention with all the leaves. So the leaves are the articles. And then you can go and read about, how to try preventive, list of preventives, long-term risks, CGRP antibodies, Botox, and so on. So this is how the migraine tree is organized. So we hope that the tree is helpful to you. The second thing you can do is use a headache diary. Maybe your doctor is not asking for one. Maybe your doctor doesn't know he or she should be asking for one. But we recommend you to do a diary. You can do paper, you can do an app. If you do an app, please try the Canadian Migraine Tracker. Once again, this is a Canadian resource. It's been designed by the Canadian Headache Society, and it's designed to be simple. Stay tuned for more videos on about how to use this, because this is really, migraine cannot be seen on an MRI, but it can be seen on a headache diary, right? So the MRIs and the CT scans are not very helpful to manage migraine. A headache diary is. A headache diary is like the TSH if you have thyroid problems, or creatinine or glucose if you have diabetes. So it's really something, just gives you an idea how things are, and it can help. Okay, so we hear a lot from you that GPs don't know a lot about migraine. We hear it, we know it. Luckily, the Canadian Headache Society, which I'm very privileged to be the president of, has designed a program to teach GPs about migraine. This is a full-fledged program, accredited, which means that they can get credits. And this is going to be launched in July, just very, very soon. We're just finishing the last little pieces. So stay tuned, because you might actually, we will give you more information, and you might go to your GP and say, hey, I heard there's this great program by the Canadian Headache Society about migraine, and maybe, you can have a look at that. We all know doctors might not, might be sensitive about being told what to do from patients, but, advocate for yourself. If you find that your doctor doesn't know, or your doctor says that, oh, I'm not sure, I don't know, here's where they can find training. Another thing you can do is involve your pharmacists. So pharmacists are great people. They know tons about medications. And I want to share with you a resource that is led by the McKesson Group, which is a pharmacy distributor group in Canada. It's called the Migraine Pharmacy Network. This is actually a great program. I had the privilege of working on it. And this allows you to book an appointment for migraine assessment with a trained pharmacist. You can do this online on the well.ca platform. So you go at well.ca and you just type migraine, and then you'll find this this website. And of course, it's it's a commercial website. You will see different things about migraine that could interest you, supplements, pillows, and so on. But you can book this assessment, and then the pharmacist will go over your migraine situation with you, design a global care plan involving everything, and then sending to your treating physician. So this can actually help you revising your migraine story and checking what you've tried so far, what happened, and the pharmacist can then make recommendations about maybe this person should try this or that, right? So that's a very interesting option. We know it's very difficult to find headache clinics, and we just put up a headache clinic locator. This is a bit of a challenge because there's no clear definition of what a headache clinic is, but we are working very hard to add more clinics, and soon we'll have also pediatric headache clinics in there. So have a look, but it's not yet complete, and we really hope to develop it so you can find access to a headache specialist in Canada. If you want to find a Botox injector, so once again, this is a website that is managed by Allergan Canada or AbbVie now. This is a very useful resource if you are looking for a Botox injector. Some of these injectors are also headache specialists or pain specialists, but some are, people, cosmetic surgeons who do who have been trained to treat migraine with Botox, but not all of these injectors will provide a global management of migraine, right? But if you have someone who says, yes, I think Botox is good for you, and you're looking for someone and you want to look by postcode, mychronicmigraine.ca can be a very good resource. And I think the website is going to be soon updated in an improved version. So we're close to finish now. We'll have time for questions. I've been dealing with people with migraine for 12 years now, plus my fellowship. And all the team of Migraine Canada is like me. We want people to get better. Okay, so we really want to help you. But to help you, we need your voice and support, because this is a public healthcare system in Canada. And this is not a system led by money. It is led by our people and you who are voters. So here's our petition, and here's what we're working on. We want people with migraine not to be blamed or shamed or stigmatized. We want healthcare providers to be educated about migraine diagnosis and treatment, very important. We want that treatments, evidence-based, effective and science-based treatments, whatever treatments these are accessible. That includes drugs, behavioral, neuromodulation, anything. We want employers to be informed about the impact of migraine in their workplace, so you can get accommodations and you can be recognized as a worker, in the workplace and not be stigmatized. We want teachers and school personnel to be educated to better support children with migraine. So we're working on all of this. There's more. We want that people with migraine are protected from financial abuse by a group who sell you cures, right? Sell you stuff, and that's not proven effective. We want that migraine will be recognized as a cause of disability. How many patients, are off work because of migraine and struggle to actually find, to have their disability recognized? We want headache medicine to be supported in departments of neurology and family medicine and any other department, so doctors are trained properly, and research is being done also, which in Canada is really lacking. And finally, we want associations to support people with migraine to find information, find support, and advocate for better quality of life. So this is really our dream. This is what we're going to do. And if you want to lend us your support, well, go on our website, Facebook, Instagram, LinkedIn, wherever you want to go. Listen to our podcasts, whatever you prefer, videos, podcasts, PDFs, website. We hope we can help.